Tonight on Community Connections, we're going to talk about the need for a good night's sleep and how you can go about getting one. I'd like to welcome both of you to Community Connections, Sunil Kumar and Dr. Robert Kosinski, both from Monmouth Medical Center, and the practice, I think, is also over Jersey Shore.
The practice is at Monmouth Medical Center, Jersey Shore Medical Center, and our private offices in Eatontown.
And your pulmonary, it's a pulmonary practice, but what we're really here to talk about today is our sleep disorders and things people can do about them.
Correct, and we're also trained in sleep medicine, which is an emerging field and a growing field. What
sends someone to you? I mean, we've been talking before. Everybody goes through nights where they don't sleep. I mean, you know, if you have your own business and you worry about paying the bills, or for me, you know, I wake up at 3 o'clock in the morning. People think it's politics, but it's always work related. And you're thinking about something you need to do or you didn't do. But that's not what sends people to you typically.
No, I think there are two main reasons why someone will be seeing usually their family physician first regarding problems. First is if it's to the point where it's not an occasional problem. We all have occasional nights of insomnia or where it's stress related, where you can identify a problem and it's related to that. But if it gets to be a more chronic problem, or you're having difficulties where it's starting, your problems with sleep is starting to interfere with your daytime function, that's when many people will seek the advice of their physician. The other time that we'll see people is more if their spouse brings up a problem that they may not be aware of, namely more in regards to sleep apnea, which is a problem where a breathing problem during sleep that the spouse may notice, either loud snoring, breathing pauses, and she will alert the patient or report this to the family physician, and then they may be sent over either to the sleep laboratory for a sleep study or for a sleep medicine evaluation.
Well, the sleep laboratory is where you come in. Correct?
That's correct, yeah.
What goes on there? I mean, if I come in and I'm a potential patient, am I spending the night with you guys?
That's true. You go to your family physician, as I mentioned, and then the family physician gives us a call, and we contact you. And we send a referral to your family doctor to get all your history and everything, what's wrong, what's going on. And after we get that, we'll schedule you an appointment. We'll give you a time to come in the night, and before you come, we send you a questionnaire which explains exactly what's expected of you.
What kind of questions are you asking?
Now, these are the questions where we'll say, okay, how much do you weigh? How much is your height? How long do you sleep in the night? Do you wake up this many number of times? Do you kick your legs in the night? Do you snore? Is there a problem with your dreams? Do you dream? You don't dream? So these are all general questions.
What you're trying to rule out stress-related sleep disorders and try to see if the person's, you know, very overweight. I imagine, does smoking enter into this at all?
Exactly. We do want to get a general impression of what we are looking at. We know you have a sleep problem, but we want to get a basic idea. You know, how much your weight is, do you smoke, not smoke, that kind of thing.
It's an extensive questionnaire, and it may include questions that your family physician or even the referring physician may not ask. Typically, there may be things that keep you awake, chronic pain, restlessness. Sometimes we see people with restless leg syndrome, and these are not addressed, may not be addressed beforehand, but we get an idea if there's something there to look at the severity or whether that will have certain findings during the actual testing during the night. Also, it's important to look at the history because many times we'll make treatment recommendations, and they'll generally be different from a young, healthy person who's coming in for snoring and apnea, or someone who has an older person who has heart disease or chronic lung disease. So the recommendations that you would make is based on the total patient, not just
Now,
what you find.
after they fill out the questionnaire, what happens next?
Right. Then we give you a time, we schedule you for an appointment, and you come in the night. Once you come in, you are greeted by our sleep technologist in the lab. They'll take you to a room and show you the room. Now, these rooms are not typical hospital rooms. These are more of a hotel-type rooms. They have a queen bed, a TV, VCR, attached bath. So we want to make the room as homely as possible.
You don't want the patient to feel stressed at being in the hospital.
Exactly. We
You want to
want
get the night's sleep.
That's absolutely right. We want to make sure that it's like your home. And once you're there, the technician will take you to another room where we have all these electrodes. These are little metal discs with spaghetti type of wires that go on the scalp, on the skin. So they'll give you a little tour of that and show you that these are going to go on your body. And then you go back to your room, you watch TV, read a book, relax till the technician comes again to tell you, okay, now we're going to go and put all these wires and these electrodes on you.
And those electrodes are going to measure all sorts of different things that are going to tell you where the sleep disorder. They're going to give you something to measure.
That's correct. Now, you have these electrodes that go on your head that'll measure your sleep. This will measure different levels of your sleep. We call it sleep stages. It's like when you are drowsy and light sleep and deep sleep and when you start dreaming.
The REM. I mean, I remember that somewhere from school.
Basically, it gives us an idea of what stage of sleep you're in during the night, how much of
Is that a
sleep-
brainwave measurement?
These are brainwave patterns that you're looking at. It is not the same as a full EEG you may have from a neurologist, but we get an idea of what stages of sleep you're in, if your sleep is being disrupted during the night, and that gives us the main idea about how you sleep during the night. Aside.
Presumably, the patient's going to spend the whole night and try to get his 8 hours or whatever it is that he gets while he's there.
Correct.
That's correct.
It's never quite as a normal night's sleep because you're hooked up with all the wires and you're in a strange environment. We will have the patients bring their own pillow in or anything that they're used to sleeping with to make them more comfortable. But from that, the other leads that are attached, we look at the breathing channels, the chest wall movement. We look at the oxygen levels with a little probe on the finger. We also look at the airflow through the nose and the mouth to see if there are episodes where you're trying to breathe but there's no airflow. We also have leads on the legs to look to see if there's any movement disorders during the night. And we monitor the heart rate and rhythm to see if there's any abnormal heart rhythms during the night, which we occasionally pick up that patients may not be aware of also.
So you're the one who reads the test results.
That's correct. Once this test is done, then in the morning, I'll come and I'll go through the entire night study. This can be anywhere from 6 to 8 hours of record. And this is stored on a computer in a digital format. So my job is to come first and see all these different stages of sleep. Tell when the patient was awake and when the patient was in different stages of sleep. Next, I would go and check all these, the flow sensors that we have placed on the nose and see when you stopped breathing in the night. And next, we'll go and review all the leg movements and see if you were kicking your legs in the night.
Is that related to if someone has sleep apnea, are they more likely to have a leg movement problem while they're sleeping?
Correct.
Are the two related?
You may have, if you're having breathing pauses during the night, if you're aroused from sleep, you may have body movements or leg movements, but there are also a separate disorder called periodic leg movement disorder or periodic limb movement disorder, where you may have movements during the night that can interfere with sleep. And the treatment for that is much different than that of sleep apnea because it's not it's more of a neurological type of problem as opposed to a respiratory problem.
You're not kicking yourself awake or anything like that?
You may be kicking yourself awake.
Not because of the sleep apnea,
but not because
though.
of the apnea. You may be having these periodic movements that can disrupt your sleep.
We're using the phrase sleep apnea a lot. And tell me what it is.
Basically, the main focus that you will see or hear about in the media is called obstructive sleep apnea, or a problem where the airway closes off during the night.
Airway where?
Usually in the posterior pharynx.
which is you're grabbing your
The
throat.
back
So I
of the
assume it's right
throat,
there.
in the back of the throat. The trachea or your airway here is a fixed structure. The back of the throat is where extra tissues may be, large tonsils. You may have a long uvula, that little part in the
thing that hangs down that
on
nobody
back
knows
of
the
your
name
throat.
of.
So
What is the name?
It's called the uvula.
Okay.
So what happens is normally when you lie down and go to sleep, your airway closes off some, just positionally. Plus, you have a certain muscle tension there, and the airway relaxes. Now, in some patients, what will happen, there'll be excess relaxation of the airway, so that when you breathe in, the airway can close off. Also, if you have extra tissue there, it predisposes you to closing off. Similarly with snoring, one of the main symptoms that may bring attention to possible sleep apnea is loud snoring. If the airway is nice and wide open, there's no sound made. If there's extra tissue flopping around in the back of the airway, or the airway is narrow and the airflow becomes turbulent, that's where you begin snoring.
What happened? I mean, snoring, I don't know if everybody snores, but from time to time. Is it a symptom of anything? Is it a heads up to anything, or it's just what people do? But this might exaggerate the problem.
Snoring may be a symptom of obstructive sleep apnea. Somewhere around 20–25% of the population snores at some time or another. If it is very loud and disruptive, if your spouse or will notice that you have irregular breathing or pauses followed by a loud snorting or an arousal, that may be more of a sign of obstructive sleep apnea during the night.
It's possible, though, that someone could have sleep apnea, have disrupted sleep, and not really know it.
Correct.
Okay. How somebody? What are the heads up that people need to look out for then? I mean, some people don't have spouses to say there's something going on here.
Correct. The main thing that we would look for then, or that may be reported, is someone feeling tired, sleepy, or fatigued during the day, or feeling unrefreshed in the morning, like you didn't get a good night's sleep. Even though you had 8 hours, you still wake up. Sometimes it's described as having a hangover effect, feeling foggy in the morning. You may have headaches in the morning. Throughout the day, you may be excessively sleepy, where you'll doze off either when you're doing sedentary activity, reading, sometimes at computer, during meetings, if you're at work. Other times, people are sleepy to the point where they'll fall asleep while they're driving or during dinner at the table.
Those kind of symptoms, excessive tiredness, are as much as the disruption in sleep that they're going to know about, are what's going to send them first to presumably their primary care physician and then to you guys.
Correct. They'll present that, as with almost any other medical problem, when it starts to interfere with your daytime functioning, then you're going to seek medical attention for it.
But it seems like this could be one, there's a little bit of time lag between it's a medical issue.
Correct.
You could have this problem for quite a while and I just have a hard time sleeping.
Correct.
I mean, a lot of people say, I have a hard time sleeping.
Correct. We see that quite often, that someone will have either mild snoring or feel a little bit tired during the day for a long period of time, for years, but then something else changes. They put on extra weight, they have more tissue in the back of the throat, the snoring is worse. Either they cut down on their sleep hours, now they have a little sleep deprivation, which is another major problem, sleep deprivation, especially in the United States, and certain groups and teenagers who need more sleep.
And a lot of time, the symptoms can be very vague. It's just a little fatigue and,
something we all go through
exactly,
from time to time.
And it's nothing specific. So people can live with this for a few years, 5, 10, 15 years, before they start, thinking that it's really a problem.
All right, well, let's take a break, and then we're going to talk about what you guys do in terms of treatment for these kind of problems.
Great.
Thank you.
Come on, buddy. Let's go.
Dad, did you ever do drugs?
Yeah, I did, and it was a dumb thing to do. But no one ever talked to me about it. My dad never talked to me about it.
Talking to your kids about drugs can be tough. Need help? Get help. Visit our website at drugfree.org.
Why do I call it a funny bone?
Why can't penguins fly? Like to see something.
Can we go to the moon on vacation?
If you think it's tough answering these questions, imagine the ones you'll get if your child is diagnosed with cancer. CureSearch.org can help. It's run by doctors and scientists whose research has led to an overall cure rate of 78%. You're not as alone as you feel.
I'm back with Sunil Chandra and, Kumar, and Dr. Kosinski. We're talking about sleep deprivation, sleep apnea, and the treatment that your patients get. After they go through the night of sleep in the lab, what happens? You read the results, you see where the disruptions are, and I assume you start to figure out what's causing them almost right away from the results?
Correct. That, along with the clinical history, we'll look at and determine what is the most appropriate treatment for a patient. And
clinical history meaning what?
The clinical history, the specific problems they're having with sleep, not only what we find on the study, because sometimes they don't quite match, as in any time you expect something to be very bad and it may not be. For instance, occasionally we'll see patients who have, on the study, severe sleep apnea, but their symptoms may only be mild during the day. Other times we'll see patients who have mild apnea, but they may be very sleepy and be very sensitive.
Could that relate to, some people will tell you, I only need 4 or 5 hours sleep a night and I'm fine. And other people, if I don't get my solid 8 hours, I'm a disaster.
Correct. Absolutely. Every person, every individual is different in their sleep requirements. And we make general recommendations that most patients need 7 to 8 hours sleep. Probably if you're a teenager, more 7 to 10 hours of sleep. But you need those hours. And some people can tolerate sleep deprivation better than others. So many times we see people tolerate them. They may not be their functional best, but they get by and they survive on the hours that they have. So that's one of the things we look at during in interpreting the treatment of the patient. The first is what particular type of sleep disorder, if they have sleep apnea, if they have a movement disorder in sleep, or if they have insomnia, and then going back, we'll decide what is the best treatment. Looking at the sleep apnea, which we've been talking about it more so, there are several treatments that are available. The basic thing that we recommend is, one, make sure you get enough sleep, so you're not sleep deprived on top of this other sleep disorder. Weight loss. Weight loss is important because when you gain weight, you gain tissue everywhere, including in the back of the throat. Men generally notice that as they gain weight, their collar size is increased, and that's actually one of the key things that we ask on our questionnaire, because if you have a size 18 neck or higher, there's a good chance that you're going to have some sleep apnea, just from looking at the physiologic studies there. So we'll weight loss, maintenance of adequate sleep hours. There is surgical techniques.
Is that a last resort, the surgical techniques?
It all depends on the age and also the type of obstruction present. If there's a nasal obstruction, which can be a cause of sleep apnea,
deviated septum?
Deviated septum, adenoids that are enlarged, which are tonsillar tissue basically along the nasal pharynx. If they're obstructed, they can be cleared out. That's very effective. In children, large tonsils are a common cause of apnea. Children have small airways, big tonsils. Usually as adults, your airway gets bigger, your tonsils shrink away. So although we occasionally see adults who have big tonsils, and that's one indication for having a tonsillectomy, and actually for more so now than recurrent infectious in children.
I had mine taken out as an adult because of the infection.
Recurrent.
Not a fun procedure.
No, especially as an adult.
Yes.
Better tolerated as a child. But as where at one point tonsillectomy was performed most often for recurrent infections, now sleep apnea has probably overtaken that as a indication for tonsillectomy.
What's your role as the technician?
Right. Now, after Dr. Kosinski, finds out that there is sleep apnea, then the patient will come back to the sleep lab for the treatment part, and that's called CPAP. It's called continuous positive airway pressure. Now, what we are trying to do, this patient stops breathing in the night. In other words, the breathing passage collapses. So by throwing the air, it's just the room air. We have a little box machine called CPAP, and it just takes the room air.
Not pure oxygen or anything like
Not
that?
pure oxygen, and it pressurizes it and sends it into the patient's airway. Now, if the patient's airway starts to collapse, we'll increase the air pressure a little bit.
It reads it in effect reads the
We
width of the opening in the throat?
Well, we won't read the width of the opening, but we will see that the patient is going to stop breathing now, and the oxygen saturation will start dropping. So,
Okay.
so once we see that, we'll increase the pressure a little bit.
You're doing this in the lab, or the patient's home and the machine's doing it?
This happens in the lab.
Okay, so he comes back to you and spends another night with you guys?
Exactly.
Sometimes if a patient is very bad, where they have a good amount of sleep apnea at the beginning of the study, we will wake the patient up and say, you have severe apnea, and right during the night, we'll place them on the nasal CPAP, which is one of the treatments, as Sunil is going over, and this way they can be treated in the same night. Other times we will have the patient return, because you want to adjust the pressure, one, so it takes care of the snoring and all the airway obstructions so the airway doesn't collapse, and two, if the pressure is too high, it'll disrupt sleep from being too high. If it's too low, it won't take care of the snoring and the adjustments, the obstructions.
Is the intention to fine-tune the CPAP because he's going to take it home? He or
Correct.
she is going to take it home with him?
Correct.
So the person is part of what you're doing is adjusting it because the person's going to need this to sleep.
Exactly. We're trying to find out the optimum pressure where this patient will not have any more sleep apnea, the snoring will cease, and the patient will sleep through the night. So one of the indicators that we use once the patient goes into the dream phase, what we call as REM sleep, and the patient's
Rapid eye movement. What is
rapid eye movement.
Your eyes aren't moving though, or are they? I don't
Actually,
remember that
they
from
are
biology.
moving. When you're sleeping and dreaming, your eyes are moving, and we can see that on our graph.
Okay.
And that's the stage in which the person is most prone to getting sleep apnea. So we'll see that this person's now.
Why?
That's because
your deepest sleep is the one that gets disrupted the most?
Not necessarily. Usually we'll think of slow wave sleep or a certain pattern as the deepest, most restful sleep. During the REM sleep, there is actually somewhat of a cutoff between your brain and your body, where your brain has very high activity, but the body is resting. You have more muscle relaxation, and this is the word I'm looking for is embryonic type of normal body adjustment, so you don't act out your dreams.
Okay.
Because there is a disorder called REM behavior disorder, where people, usually it's seen in older men, sometimes they're related to strokes or other cerebral type of conditions.
This is a serious issue.
Where they will lose this inhibition. It's an active inhibition of muscle activity.
Gotcha.
So if you lose that, then people start acting out dreams, and these may be the people who start fighting the monster or the dragon at night. They'll hit their spouse, they'll run out of bed into the wall.
Would this be what people commonly call sleepwalking? Is this when that would occur? Is that something?
No, that's a little different. That occurs usually out of a different stage of sleep, not related to REM sleep. That's what we usually would call a parasomnia, or an abnormal behavior during sleep, sleepwalking, sleep-talking.
How uncommon or common is that?
The REM behavior disorder is not that common. Sleep-talking, sleepwalking, parasomnias, grinding teeth, anything else you do during the night is fairly common.
I mean, everybody does that at once.
Correct.
Those kind of things. You know, as we're talking about the treatments, how essential? I mean, a good night's sleep is essential to normal and productive functioning.
Correct.
What percentage of people go without?
That's hard to say. Sleep disorders is a major problem. At some point in time, we all have insomnia, whether stress-related. They estimate billions of dollars of lost productivity, and on a yearly basis, if you look throughout the country on how much it costs. So, workplace for people not being optimum functioning related to insomnia, sleep apnea.
How big an area of medicine is this becoming? I mean, I can't imagine that it's. I mean, it sounded to me that this is something almost a growth industry.
It is, and over the past 20 years or so, it really has been. There's been a proliferation of sleep laboratories across the country, not only sleep centers, laboratories, even here in Monmouth County. Initially, when we started, there was one center. Now every hospital has their own center. There are a lot of freestanding sleep labs. So it's the number of laboratories has grown, the number of physicians, and also physician awareness of the problem. This upcoming May is Sleep Awareness Month.
Sounds like proclamation time.
And it's also not only, so it's grown not only in the medical community, it's become a more accepted field of practice. There are separate board certifications for sleep medicine. It's been formally recognized, say, by the American Board of Internal Medicine, who has their own board certification now.
Are most of the doctors who are involved in it like you? There are pulmonary specialists who branch out into it, or are people coming out of medical school specializing in that now? It's
a variety. As with other growing fields that eventually become very specialized, initially, the people who have been doing it will become board certified. At some point, to become board certified, you'll have to do a separate training or specialized training in that area. Looking at this going back, in addition to my pulmonary training, I also did a separate sleep medicine fellowship, separate from that, to get my board certification. That was probably one of the earlier ones. It was several years ago.
How long have you been doing this?
Probably 17 years.
We were talking, kids have different, I don't know if you have children, but you have a 15-year-old, I have an 18-year-old.
I have 3 kids.
Okay, getting them to sleep.
Yes.
I mean, part of what doctors are trying to do and insurance companies are trying to do, have good, healthy habits to avoid hospital stays and doctors and all of this. How hard is, how essential is that the kids get into these habits?
Oh,
Do you preach those things too?
Absolutely. Sleep deprivation is one of the biggest problems in America. We all are up late playing on the internet. It's a 24-hour society.
Doctors are known for it. Medical
Correct.
students and interns and
teenagers, very difficult with their hours, school, homework, sports. We'd like to see them get anywhere from 8 to 10 hours a night would be optimum for teenagers. It's very difficult. They're up late.
Getting up early.
It's
Last
a very
year,
difficult
actually,
situation.
I was giving a lecture in a high school, and I asked these kids. First, they asked me, "Oh, how much sleep we should have?" And I said 8 to 9 hours. And I asked
laughed
them,
at you.
Exactly. That's exactly what happened. And I asked them, "How much do you sleep?" They said 3 to 4 hours.
Well, that's really tough.
And a lot of them were falling asleep, and you could see they're groggy.
And then they get behind one of the scary things is for all of us when we're really tired, we get behind the wheel of a car. I hope this sends people in your direction, thinking that they need to pay attention to these issues. It was a learning experience.
And it's a very satisfying field, because if you do treat the patients and they notice a world of change in their functioning and their alertness during the day, so it's
they feel better. You've done something really good for them.
I heard someone say in the morning once, he said, "I never slept like this in 25 years.
And sometimes the change can be dramatic.
That's good. Okay.
So it's a very satisfying field.
If that doesn't get people's attention, I don't know what will. Thank you very much for coming over.
Thank you very much.
Thank you.